Good evening, and thank you for joining us for another session of the Cancer Care series. I'm Anisha Layardhavan, your host today. We will be discussing the thyroid cancer and the current challenges in its treatment. Thyroid cancer develops in the thyroid, a small butterfly-shaped gland at the base of the neck. This gland produces hormones that regulate your metabolism, which is basically the thyroid secreting hormone. Did you know that women are 3 times more likely than men to get thyroid cancer? Did you know that in most cases, feeling a lump or growth near your neck is among the most common signs of thyroid cancer? Thankfully, thyroid cancer is highly treatable with an excellent cure rate. Now, there are many different kinds of thyroid cancer. In our show, we will discuss them in detail. We'll also discuss who is at risk of having it and what are the challenges in its treatment. This show is supported by Eisai Pharma. Please welcome our expert who will discuss thyroid cancer with us in detail. We are very happy to welcome Dr. G. Vamshi Krishna Reddy, consultant, medical oncologist, Yashoda Cancer Institute, Hyderabad. Good evening, Dr. Reddy, and welcome to our show.
Yeah, good evening, Anisha.
Dr. Reddy, thyroid cancer, thyroid is a gland, and there are many glands in our body. So how does thyroid cancer happen? It happens in the thyroid gland, but why in this particular gland and how does it happen?
So for cancers to arise, no part of the body is immune to not develop cancer. Mm-hmm. So unfortunately, if the cancerous cell, it grows from the thyroid gland, we call it a thyroid cancer. So anything which arises from the thyroid gland and it turns into a cancer, we call it a thyroid cancer. Mm-hmm. So of the various glands, why only thyroid? Yes, we do see cancers arising even in other glands also. But the commonest cancer, because it's easily visible, and for anyone, obvious thing first you look at is the face or the neck. So that's the reason probably we see more cases of thyroid cancers being diagnosed.
All right. And are you able to easily diagnose this or find out that something is wrong? Because you said it's easily visible. This is obviously not a very deep-seated cancer, which are sometimes very insidious. So do you see more patients in early stages of thyroid cancer?
Yeah, fortunately for thyroid cancer, because as you rightly said, it's visible on the neck. And most of the times the patients themselves do come us asking to check what's the swelling on the neck is. So that's one part of the story. The other side is probably they will be doing more scans now. I think for the last year or so, we have been doing more scans for COVID also. So in that we were detecting small nodules in thyroid, because once you get a scan of the chest, neck is also included. So most of the times thyroid cancer does not cause symptoms. So it's incidentally detected either by the doctor or the radiologist or by the patient himself or herself. So it's very easy to diagnose thyroid cancer because it's visible as a neck nodule. So you see some swelling on the neck. And if you're suspecting abnormality, we do an ultrasound and then we do diagnose it appropriately.
But Dr. Reddy, why are you calling it incidental diagnosis? During COVID times, we are more careful. Many would perhaps have got a scan, a chest X-ray done in case they had fever or something. But should this not be the case, then will the diagnosis still be incidental?
Yes, I think incidental is why I call it. Most of the times thyroid cancers don't cause any symptoms. So it's either the patient or their family member or friend who will be noticing that something is moving when they're eating. So because you can see that the thyroid gland, if there is swelling, it moves while eating. So it's not diagnosed by the patient. Most of the times it's by their family members, or very rarely a very watchful patient will be seeing the nodule and coming to the doctor. So because it does not cause symptoms, I will tell it as an incidental thing because it's asymptomatic for most of them.
Okay, mostly asymptomatic. And how common is thyroid cancer? In India, we have seen that breast cancer is fairly significant with women. There is also a belief that thyroid cancer affects more women than it affects men. Is this true?
Yeah, thyroid swellings, goiter, thyroid nodules are more common in women than men. So probably we'll put it as more 5:1. So that's the ratio we see in our practice. So again, varies from the place we practice from area to area. But throughout the world, it's a proven thing that thyroid nodules or swellings or cancer, all of them are more common in women than men. Why? Yeah, probably because thyroid has more iodine requirement and women do have more requirement, and probably that's the reason they have more nodules. And that's probably the case where we see more of these thyroid swellings in women. And in India, do we see thyroid cancer? Yes, we do have good number of patients with thyroid cancer. Incidence wise, yeah, probably it should be somewhere in the top 10 cancers in India. More common in women, less common in men.
All right. Now, in our country, in India, we have read in textbooks about something called goiter, a large growth around the neck. And what we also read was that, with the onset of iodized salt, all this, disappeared. Now, does goiter have anything to do with thyroid cancer?
Yeah, I think 2 decades back when we were probably studying undergraduation in medicine, we used to see thyroid swellings as goiter. I think the last decade or so, the number of cases with thyroid swelling have drastically come down, thanks to the government of India's initiative that most of the salt which is sold is iodized. So we don't see any iodine deficiency disorders now. So it's probably what was taught earlier. And this goiter is a benign thing. So it's because of iodine deficiency, we see the thyroid gland growing up to secrete the hormone, the TSH hormone, which we're talking about. And it's a benign thing. So it does not change into cancer. So most of the times the thyroid swellings are benign. So they don't cause problem. So it's mainly colloid goiter or nodular goiter is what we call. So almost if we are seeing 100 swellings, probably incidence varies. So around 70 to 80 will be benign. The chance of it being malignant varies according to the age and sex. So it should be somewhere within the range of 10 to 30% that it being a cancer of all the swellings. Goiter does not change into cancer. So it's a different topic altogether. So goiter is usually a generalized swelling, or it can be a nodular goiter. And of late, we are seeing definitely the generalized, the big swellings which we used to see earlier, we are not seeing those.
So would you say that, goiter has largely reduced in our country? So if there is a swelling, you should not rest easy. If there is a swelling in your neck, you should get it investigated, not think this is something which will go away on its own.
Yeah, if there is a swelling which is persistent, the first thing which you have to do is visit your doctor, preferably an endocrinologist. What we usually do is we get a thyroid profile where we check the hormones, the thyroid T3, T4, and the TSH.
And this is a blood test? A thyroid profile is a blood test?
Blood test. So it basically checks whether the thyroid gland is functioning properly or not. So if it's a normal functioning thyroid, then definitely that nodule or swelling needs to be evaluated. The next test which we'll be doing is a scan, which usually is an ultrasound scan. It's quite safe. So we use the ultrasound waves and check the swelling on the neck. And that ultrasound gives an exact picture of what it can be. So at times, if it is suspicious that it's not normal, it can be an abnormal cancerous swelling. What we do, the third step, which uses a needle test. We do a FNAC. So we do a needle test from the swelling and test it and see the cells. So if it is cancerous, we call it as a cancer. If it is a normal thing, most of the times we get it as a nodular goiter also. It's a benign thing we put under follow.
All right. Now, you did mention that women are more prone to getting thyroid cancer. Why are women more prone? Because like breast cancer, it's a sex hormone related cancer because it's many times related to estrogen. Now, thyroid is something that everybody has. So why are women more likely to get thyroid cancer? And who is at risk of thyroid cancer? Is there any way to know if anybody is at higher risk?
Yeah, I think the incidence of thyroid cancer in women is more per se because, as I said, we see more swellings in them, more thyroid swellings in them, mainly that they have more requirement, probably because of the pregnancy thing and all this normal physiological changes which happen in women. And second thing, what you asked is who are at risk and when can they be at risk. So the main risk factors for thyroid cancer is the radiation thing. So quite long back, we used to treat most of the cancers with radiation to the neck or so. So we see cancers developing after a decade or so in them. So if this part of the neck is exposed to radiation, so which usually happens in medical treatment for some cancers, we do give radiation. So that's one common risk factor for developing thyroid cancer. Other than that, there is no proven thing that this thing can cause cancer, like whatever hormones. And the second thing which you're asking is, as breast cancer is seen with hormones, do we see the same thing in women? No. Thyroid cancer is not caused by the sex hormones, which are estrogen and progesterone in women. So the TSH is not a sex hormone, it's a thyroid stimulating hormone. So it's not produced by the thyroid per se, it's produced somewhere in the brain, so from the hypothalamus. So it's not related to the sex hormones thing. And is there any other risk factor? Yes, we do see few types of thyroid cancer which happen as part of the hereditary cancers. So if there's a first degree relative, like a sibling or parent, either of the parent having a thyroid cancer, the chance that the next person might be developing a hereditary cancer, thyroid cancer, is high. So the hereditary thyroid cancer is a known thing. So it happens with a few hereditary cancers like the medullary carcinoma, which we see. It happens in hereditary way. So other than the hereditary thing for few cancers and the radiation thing, there are no other risk factors which prove that this can cause thyroid cancer.
Right. Dr. Reddy, you said that there are some kinds of thyroid cancer which could be, caused because of your genes. Are there only some kinds of thyroid cancer that are, genetically predefined or predisposed? And what are the different kinds of thyroid cancer? Because, thyroid is a gland and has cells, but there are 4 different types of thyroid cancer. Could you tell us more details?
Yeah, so I'll be taking the second part first. So what are the types of thyroid cancer? So we have mainly two different types. One is the differentiated thyroid cancers, which we call as follicular and papillary thyroid cancers, the undifferentiated being anaplastic. And the third one is medullary carcinoma of the thyroid. So the first differentiated thyroid cancers, the papillary and follicular, usually don't happen in the hereditary way. So they happen sporadically. Sporadic means it can happen to anyone. And most of the times, these cancers are diagnosed in an early stage and they are curable in a big way. So I think most of them have a cure rates of more than 95 to 98% for the differentiated thyroid cancer. The next is undifferentiated thyroid cancer, which we call as the anaplastic thyroid cancer. We've seen very few numbers of the thyroid cancer. So more the differentiated contribute approximately 70 to 90% of the thyroid cancers. The anaplastic variant is an undifferentiated variant, and unfortunately, it's a bit aggressive cancer and quite lethal. So anaplastic is one cancer which we see in very few numbers, but it's a bit aggressive. The last one, which I was talking about, the hereditary thing, is a medullary carcinoma. And this usually is part of the hereditary cancer syndromes. So most of the times we see medullary carcinoma, we do suspect that probably this patient is having a hereditary thing. So if we are diagnosing a medullary carcinoma, we also do test for the hereditary cancer syndrome. So this type specifically needs to be tested for the hereditary resistance panel testing.
All right. So now you understood the different kinds of thyroid cancer. Could you tell us what is the treatment protocol? You said that it is most of the thyroid cancers are highly curable. You gave success rates of 90-95%. So how do you treat them?
Yeah. So what's the first thing is, how do we see them? So how do we diagnose them? So as I was speaking earlier, the reason I said that they are highly curable and the cure survival rates are very high is because we do diagnose these cancers very early because it's visible on the neck. So the same thing does not apply to other cancers because they do happen internally. So second thing is, how do we treat them? Yes, again, it depends on the type. So as I was saying earlier, so once we see a swelling and we do suspect that it's not normal, either by the ultrasound or by FNAC, the first test we do is we do a scan and see whether it is localized. So once it is confirmed that it's a localized disease, the first and best treatment is surgery. surgery includes removal of the thyroid gland. So at times, based on the size of the tumor, we decide whether we remove only that part of the lobe or removing the total thyroid. So most of the times, the patients do end up with total thyroidectomy. So that means they remove the whole of the thyroid gland. And fortunately, we have neck creases. So we have a small incision where we remove the thyroid gland from that incision, and probably because of the neck creases, it's not even visible. So surgery is the best treatment for thyroid cancer. And after surgery, again, because the patient goes into a state where thyroid hormone is not produced, so they have to be on medications for the rest of their lives. Post surgery, based on the staging, so we see whether the thyroid size, the tumor size, the spread to the adjacent lymph nodes, we decide whether the patient needs further therapy with radioiodine. Radioiodine therapy is one therapy which we give in only thyroid cancers. So most of the times patients do ask us, so they're afraid, once surgery is done, sir, do we need to take chemotherapy? So yeah, unfortunately for thyroid cancer, the treatment post surgery includes a radioiodine ablation, or we call it iodine therapy.
So what is this iodine therapy? Does it involve ingestion of medicine? Is it applied locally? How is it different from chemotherapy? What are the risks associated with it?
So iodine therapy is a sort of a nuclear medicine therapy is what we call. So what we usually do is this iodine, as we know, that is taken up by the thyroid cells. So we are utilizing this nature's way that thyroid glands are iodine avid. So they eat iodine. So what we do is we make it radioactive. So we tag this iodine and make it radioactive. So once we inject that radioactive iodine, just like an injection, so once you give that, these thyroid cells, they eat up this iodine, radioactive iodine. So this radioactive iodine is concentrated in these thyroid cells, wherever they are in the body, if it is in the neck or anywhere else. So these cells take up this iodine. And once this radioactive iodine is taken up by this thyroid cells, what happens? This radioactive emission is there. We see this radioactive radiation coming from the cells, and that kills that cell. So that damages the thyroid cell. So beauty is that it happens and damages only the thyroid cell. Other normal cells usually do not take up this iodine. So we don't see the specific side effects which we see from chemotherapy or other therapies in thyroid cancer from this iodine therapy.
All right. So you're saying there are fewer side effects of this radioiodine treatment?
Yeah.
Okay. So that's a relief. Now, what are the challenges that are associated with the treatment of thyroid cancer? Is it so simple, step 1, step 2, step 3? Because, cancer is a serious disease, and just the diagnosis of cancer can be very traumatic for patients.
Yeah, fortunately for thyroid cancer, two things. One, that it's diagnosed in an early stage. And second is that we have good therapies with surgery and radioiodine. So with these therapies, almost 90 to 95% of the patients don't require any further therapies. So that's the beauty of treating a thyroid cancer. So unfortunately, it should not happen to anyone. But if it happens, you should be brave and strong that, yeah, it's a cancer which is treatable with very minimal side effects. Just a simple surgery where it's probably in few centers, we are doing it as a daycare basis. So you admit today and probably if everything is fine, you discharge them by the next day. So like it's not difficult surgery like as we do for other cancers.
Right. Dr. Reddy, this must be when the cancer is only in the thyroid gland. Because of its proximity to the lymph system, like you said, to the lymph nodes, how often do you see metastatic cases where, from the thyroid, the cancer has spread to the lymph, from the lymph to other places, and hence, more complicated than the normal ones? How often do you see this kind of presentation?
Yeah, the late presentations in thyroid cancer is in a very few proportion of patients. So I'll put them as very negligent patients who don't even observe.
Mostly localized. Most of the thyroid cancer patients come to you with a localized presentation of the cancer.
Yeah,
Dr. Reddy, you were talking about how thyroid cancer is largely localized amongst patients. What is the chance that thyroid cancer spreads to the lymph nodes and from the lymph nodes to the rest of the body? How many times do you see metastatic cancer because of thyroid cancer?
Yes, thyroid cancer also is known to metastasize. So though simple looking cancer swelling on the neck, we do see recurrences or relapses is what we call. So once we treat with surgery and radioiodine, at times we see again the swelling coming back in the neck, or at times it may spread to the bones or lungs. So that's the commonest sites we see. So it again depends on when or how far from the radioiodine therapy it relapsed. So based on that, we treat again with the same radioiodine therapy. Or if it is in multiple sites, we have newer targeted therapy medicines available like lenvatinib. So we usually use those medicines, the targeted therapy medicines. So we have a basket of drugs available now to treat the thyroid malignancies, even if it metastasizes.
All right. So, Dr. Reddy, you had mentioned that the most common sign of thyroid cancer is a lump or something near your neck. Could there be, could somebody be having thyroid cancer but not have a lump? If somebody has a hoarseness in their voice or difficulties in swallowing, should they also get investigated for thyroid cancer?
So most of the times, as you rightly said, it's a swelling on the neck for which they'll be approaching the doctor. So, but unfortunately, we see few patients for whom the primary site will disappear. So that's too small for it to be visible on the neck. So for someone is obese, also we may not be seeing that swelling. And unfortunately, because it's just above the airway and behind it, we have the foot pipe. So when that is involved, so we see, as you rightly said, the hoarseness of voice, a change in voice, at times having difficulty in swallowing, or at times we'll not be seeing the swelling here, but we may be seeing swellings in the lymph nodes if it has spread to the lymph nodes. So yeah, we do see these patients, but that proportion is less. So probably I'll be putting it around 10 to 20% or less.
Right. Dr. Reddy, is thyroid cancer seen in pregnant women? Could they be more at risk of getting thyroid cancer?
Thyroid cancer can happen in any age. So pregnancy does not save them from this cancer, unfortunately. So we do see thyroid cancer even in children. So, but the prognosis is different. So for younger patients, we do divide thyroid cancer into two age groups, less than 55 and more than 55. So for less than 55, most of them, they do well because it's in early stages for these patients and they're usually curable. More than 55, they don't do well. So as you asked, the pregnant women, they usually fall in the age group of less than 55. So what we usually do is we try to postpone the treatment until they complete the pregnancy. Post-pregnancy, we try to do surgery or radiation, iodine, the radioiodine, which we call iodine ablation. At times, if the swelling is big and we need to intervene, we just go ahead with the surgery and remove the thyroid, and we plan for the radioiodine therapy later. So there are instances where we have treated pregnant women having thyroid cancer with surgery. Only thing we don't do is we don't give the radioiodine therapy in pregnancy.
All right. Dr. Reddy, I want to understand from you, how does life change after having thyroid cancer, after getting treated for thyroid cancer? You said that, we remove part of the gland or the entire gland. Then how does one survive without a gland? I mean, are there synthetic hormones? How does life change post-treatment of thyroid cancer?
So fortunately for thyroid cancer, it removes involved of the thyroid gland, and also there are a few glands, that is parathyroid glands, which help in the calcium metabolism. So we have medicines which can replace them entirely. So all of us know that some of your friends or close relatives might be taking this thyroid replacement thyroid. This is available as a tablet, the L-troxin or Thyronorm, whichever medicine. So for those who have a function of thyroid gland which is low, hypothyroidism, so that's a common medicine which is available for ages. So if you are removing the gland, we put them on this medicine, the thyroid supplementation, that's L-troxin or Thyronorm, and we ask them to continue throughout life. So only one thing that would do is they should not forget to take this tablet for the rest of their life. So like it's a replaceable thing. So we are just removing the gland and replacing it with a artificial thing. We are giving the medicine.
Dr. Reddy, but does the artificial hormone work just as well as the natural one? Because, for women, they are also concerned about weight gain. And, I've seen some of my friends also have had thyroid issues, either pre-pregnancy or post-pregnancy, and then they've taken this medicine for some time and stopped. But, weight gain and the impact it has on other organs remains a concern. Could you be gaining weight because the synthetic hormone doesn't work as well as the natural one?
No, actually, I'll put it as simple. No, thyroid, fortunately, is a simple hormone, so it's easily synthesized in the lab. So it's exact replica of what we have. And do we gain weight if it happens only because you are not taking the proper dose? So if you are monitoring the thyroid levels and replacing it appropriately, if you are euthyroid, so normal thyroid state, you will not have this weight gain. If you are having weight gain, it means that you are not taking the proper dose, because the dose which we give for those who are hyperthyroid is less. So they might be taking 12, 25, or at the most 50. But once we remove the whole thyroid gland, the requirement is high. So most of them, they'll be requiring 100, 150, and the dose of the tablet will be that high. So they should take the correct dose. Without the correct dose, what happens is, what you said, they gain weight and they'll be having symptoms of hypothyroidism.
The other thing I wanted to check with you, Dr. Reddy, is that is there a screener for thyroid cancer or any way to prevent getting thyroid cancer, especially since you said some of the thyroid cancers have a genetic background. So is there a screening?
So we don't do screening for thyroid cancer, mainly for that it's not cost effective. So mainly for the incidence, and we can't test each and every person for thyroid cancer. Each swelling we cannot test. So only for those, as you said, the genetic thing. Yeah, if we have a person who is known to have a genetic thyroid cancer, like the medullary carcinoma of thyroid, we do test the family members for this gene. And if they are positive for that gene, we need to screen them with imaging, that is ultrasound of the thyroid regularly. So other than those or those who have the risk factor, that is the radiation. So who have received radiation to the thyroid gland, they also need to be screened. These are high risk population. But for the normal population like you and me, we don't need a thyroid screening. So it's not cost effective and it's not recommended. So just you can watch, and if you have a swelling, you can just check it. So it's not recommended for all.
Right. Dr. Reddy, for those who have that annoying gene that predisposes you to a particular kind of thyroid cancer, does removal of the gland prophylactically help?
So the various schools of thought, like what we do for the BRCA gene. So where if the patient has the gene, whether to remove it prophylactically, again, we have so many social, ethical issues. For the thyroid, yes, we do counsel the patients, and if we know that they have this medullary men syndrome also, we can suggest a total thyroidectomy, because compared to the breast, it's easy thing. We can just remove the thyroid, it's not visible, replace it with hormones. And that is one surgery which we can suggest if they have this high-risk hereditary syndrome.
All right. So a lot of options for patients who are diagnosed with thyroid cancer. Dr. Reddy assuring us that this is one of those cancers with a high cure rate should you present early in the disease, which again is largely the case because of the visibility of that lump in your throat, which can then lead to early diagnosis and successful treatment. Thank you, Dr. Reddy, for joining us on this program and sharing the latest advances in cancer care. Thank you so much.
Thank you, Anisha. Thank you.
So I've learned a lot in this discussion. I'm sure the audience has also greatly benefited from all the experience that Dr. Reddy has. This program is supported by Eisai Pharma. Do follow us on Facebook to get all the updates on our upcoming programs. We'll wrap up the show here. Till we meet again, stay safe, stay healthy, and take care. Goodbye and see you soon.